Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Medical Cannabis and Cancer. If this is your first time joining us, Cancer Support Community South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Without further ado, I'll introduce our workshop speaker. Dr. Bonni Goldstein is the Medical Director of Canna-Centers, a California-based medical practice devoted to educating patients about the use of cannabis for serious and chronic medical conditions. Thank you so much for being here with us today.
Thank you so much for having me. Hi to everybody. Thank you for taking time out of your day to join us. I'm going to go ahead and share my screen and we'll just get started. So let me just shrink this for 1 second so I can see my slides. All right, very good. And can you see my slides okay?
Yes, thank you.
Okay, great. Okay, so my background, just real quick, I've been licensed in California longer than 30 years. Now it's been 33 years. I guess I need to update that. I trained at Children's Hospital as a pediatric doctor. I was chief resident there. I worked in critical care transport and pediatric emergency medicine for quite a long time. And around 2007, 2008, a friend of mine was ill and asked me about cannabis. In California, we had medical cannabis approved since 1996. But of course, there's no training. You don't know anything about it. And so most doctors were hands off, which I was. And I did some research for my friend, and I couldn't believe what I was reading, that I hadn't known about this, something called the endocannabinoid system, which we'll talk about. And I started delving in, and that's around 2008 is when I switched my practice from crazy emergency room to medical cannabis. I began as the medical director of Canna-Centers, which is my practice. And gosh, we've treated many thousands of patients. And then this is my book, my second book that I wrote on cannabis called Cannabis is Medicine, which really is kind of walks that fine line between being too sciencey and not sciencey enough. It's really meant for anybody who just wants more information about cannabis. Now, I'm just going to do a very, very brief history of cannabis. I normally delve in more, but I really would like to save some of the time for some of the research. So what I kind of show everybody is before the green, so this kind of orangey yellow color, this was the time when nobody knew anything about cannabis, but it was being used as a medicinal herb. People didn't judge it. It didn't have the bad baggage that it carries now, all the stigma. There was no propaganda against it. It was just yet another plant that people used if they were sick or for rituals. And there was Dr. O'Shaughnessy was really the one he was an Irish physician who went to India and studied cannabis because it was being used there as medicine. And he studied it first in animals, dogs, and he realized even if you tried to kill a dog with cannabis, you couldn't succeed. The dogs would fall asleep and then they'd wake up and be dogs the next day. And then in the 1940s, some chemists decided to try to look at what's in it, but really it wasn't until the 1960s, early 1960s, when Dr. Raphael Mechoulam, an Israeli scientist, delved in to study this particular plant. And then in the 1980s, there was interest in using it as a medicine to treat chemotherapy-induced nausea and vomiting, because anecdotally, people who were smoking pot, remember, people smoked pot all through the 60s and 70s, people would report, hey, it stops me from throwing up, it stops my nausea, I can actually have a meal and enjoy it. So, of course, pharmaceutical companies decided to make some THC synthetic compounds, dronabinol and nabilone, still available now. They're prescription synthetic THC. And then really when the science kind of got further determined was around, this isn't exactly right, 1988, 1990. They found how THC causes the effects that we know THC to cause. They found that animals, first in animals they found it, then in humans, that we actually have a receptor in our brain and in our immune system, in our gut, it's basically everywhere, which I'll show you, that is called a cannabinoid receptor. Prior to being labeled a cannabinoid receptor, it was called an orphan receptor because nobody knew what chemical, what compound would be. It's like key, and the receptor acts like a lock, so key and a lock. So we saw the lock, but nobody knew what the key was. And it turned out that THC would bind to this particular receptor. So they changed the name from an orphan receptor to a cannabinoid receptor. And the scientists were quite smart because they decided, of course, any receptor that we have in our body is not for something that's outside our body. We make that compound that's supposed to bind to that. So we have serotonin receptors because we make serotonin. We have dopamine receptors because we make dopamine. We have opioid receptors because we make opioid-like compounds, endorphins and others that bind to those receptors. So we don't have opioid receptors for, Vicodin or Norco. We have them, the pharmaceutical company sees the receptor and creates a compound to bind to it, right? But it turns out that THC happens to be in the plant kingdom, and it binds to our cannabinoid receptor. And it turns out we make our own inner cannabis-like compounds. And they discovered, you see up here, anandamide and one called 2-AG. There's a number now, but these are the two main ones. And their job is to regulate our survival and our homeostasis, which I'll share with you. And so that's the timeline. This is really, when you think about this, wasn't that long ago. I actually went to medical school 1986 to 1990. And so when I think about this, the reason I didn't learn it in school was because it was just being discovered. But I hate to say this, but only about 14% of medical schools right now even teach about the endocannabinoid system and these compounds that we make, which is really unfortunate because they play a big role in just about every physiologic process in our bodies and our brains. This last one here is just nabiximols, which is a pharmaceutical grade, plant-based, under the tongue spray. It's not available in the United States. It is available in about 20 European, South American countries, specifically for two conditions. One is multiple sclerosis, spasticity associated with multiple sclerosis, and the second is advanced cancer pain. And the beauty of the fact that a pharmaceutical company made this is that they were able to do a ton of research on it, which helps support, and it's plant compounds. So it's the same as what you might use if you were going to take some cannabis plant material and use that. It tells us a lot about these compounds and how to combine them and how to use them. So that research has really been very helpful for us. All right, that's my little signs there. So what is the endocannabinoid system? So this is the end of a neuron. So when you think about a neuron, just kind of think about like a long arm that has a bulb at the end. And this is the end of the neuron sends messages. So this is the end of this neuron that's sending messages to this cell. So we call this the presynaptic neuron, and we call this the postsynaptic neuron. And here is neurotransmitters like dopamine, like serotonin, like norepinephrine, the messages that your brain sends. So if you eat a little piece of chocolate, your brain sends a neurotransmitter and gives you happiness, right? It turns out that these receptors, they do look like a little lock sitting on top of the cell. And what happens is if you have too much message going across, and think about what too much message is: seizures, not the message of nausea, the message of vomiting, the message of pain, the message of anxiety. These can be very adaptive, but when you, because your body knows something's wrong, but at the same time, let's say just getting chemotherapy, your body is saying poison, 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 and your body is sending this message of nausea and vomiting, right? It's telling you, hey, watch out, don't eat that again. But of course, chemo is not necessarily being eaten. And what happens is when there's too much message being sent, your body releases your own natural inner cannabis compound called endocannabinoids from this cell that's kind of irritated from that too much message. And it sends it back, what we call retrograde, backwards to the presynaptic neuron, puts you basically sending the key back. It binds to that lock, that receptor, and it tells that cell, dial down the message. And so here's the phytocannabinoid, the plant cannabinoid. Your receptor doesn't really recognize whether it's your own endocannabinoid or the plant cannabinoid. It just responds, right? It's a key in the lock. It's kind of like if you live in an apartment building and there's a landlord that has a master key to every door, but your key doesn't open everybody else's door, just different keys, right? And so the understanding is that we have these receptors, we have these endocannabinoids, and when you are being stressed, whether it's physical stress or if it's mental stress, whatever stress you have, your body reacts, sends this over message. You know, it's normal, like if a bear is chasing you, for you go, fight or flight, and go racing away. But the point is that when you're sick, sometimes your body can't keep up with releasing these endocannabinoids to help you balance those messages. And the whole idea behind medical cannabis is that you are assisting your body's endocannabinoid system by just augmenting it, giving a little extra from the plant. And your body knows how to handle it because it's natural, it's a plant. And as you know, like we have apples and we have oranges and we have broccoli. It's a plant. Now, of course, it can make you high if you take too much THC, but the point is when used medically, all you're trying to do is help your body get back into that homeostasis, that balance. And I'm going to talk about that a little bit more here. So the whole idea here, it's just another picture of it. And here's THC, here's the cannabinoids that your body makes, your endogenous or endocannabinoids that we make inside. And by the way, these are made with healthy fat. And if you think about the 1970s, 1980s, 1990s, what did they tell us to stop eating? Everything was low fat on the market. And what did we end up, when you take fat out of food, what do you replace it with? Sugar. So we all ended up with hypertension and obesity and diabetes because we all shifted more towards sugar. And I really believe that the lack of fat in our diet has kind of led to some more, not to mention the environment we live in, the stressful environment, more mental illness, because you need fat to make your inner cannabis compounds that help you stay in balance. So this is just a signaling system that sends balances that promote homeostasis. There's 3 kinds of cannabinoids I've already mentioned from the plant. I've mentioned the ones you make in your brain, and then I've already mentioned the 2, dronabinol and nabilone. These are, I think, a Schedule 3 and a Schedule 4 drugs that a doctor can write a prescription for. Dronabinol, I think, is Marinol. And there's some evidence that these synthetic cannabinoids, they've been studied, but a lot of people prefer the natural plant over the synthetic because the plant actually comes, like I always tell people, you don't hand me an apple and say, hey, doctor, can you take one compound out of the apple? No, we eat the whole apple. Mother Nature, it sounds like a hippy dippy, but the Mother Nature gives you the package, right? And when used properly, all of these different compounds can be very helpful. And unfortunately, this poor plant has been vilified for one compound, THC, out of hundreds and hundreds. Last count is over 500 compounds in the plant. And so what I always tell people is under medical supervision, this plant is incredibly safe and beneficial, again, when used properly. So I'm not going to talk about recreational or adult use or problematic use in this talk, and we know all that exists, but that's why I kind of try to educate this so that everybody understands that this is a great tool in the toolbox for physicians if it's used appropriately. Now, where are these receptors located? This is really important. It has been mapped out. So shortly after they discovered the receptor, they started doing research into where is it located. So I want you to think about 2 places, brain and body, even though there's a little overlap. But in the areas of your brain where these receptors are, it kind of makes sense how people are using cannabis. So when you think about pain, nausea, vomiting, emotion, mood, people say all the time, oh, it helps my anxiety, it helps my appetite. There's a study that came out of a professor at Harvard University, took a handful of patients that were using other drugs like opioids and other medications that got prescribed medical cannabis. And before they started their cannabis, she did all kinds of studies on them. She jokingly calls them the most studied population on earth. She did functional MRIs, CAT scans, all kinds of mental status exams, blood work, you name it. And she found that just after 3 months of medical cannabis, so not recreational, medical cannabis, that neurocognitive and function improved in these patients. And part of that was because they were likely, simple explanation, a little out of balance, and help get into balance. And that helps you when you're not so anxious, when you're not suffering with pain, when you're able to wean some medications that cause brain fog, you may have better cognitive function. We also know memory. There's always the joke, like people that get high can't find their car keys, and that's a good thing. Well, it can affect short-term memory, but a lot of my patients who are using medical cannabis and where their condition affect their memory will say they feel like their memory's better. And in fact, I was just reviewing studies on neurocognitive and neurodegenerative disorders like dementia, and there's some report cases that microscopic doses of THC, like a 0.5 milligram, very, very low dose, are helping people with dementia have some improved memory. Also in fear, sleep, motor coordination, and of course, pleasure and reward. And that's why people seek out cannabis. This increases your dopamine. Cannabis absolutely increases your dopamine, and that's why some people really like it. So here's some other areas. It can affect your body temperature and so on. And then in your body, it's all over your immune system, your inflammatory system, how your body reacts to things. It's all throughout your gut, nervous system, your reproductive organs, many other areas, basically just about everywhere. And what you see here is red and yellow are the most dense. So you see brain, gut, and then immune system is kind of what you're seeing all over here, reproductive and so on. And again, I just want to stress the role of this endocannabinoid system. Dr. DiMarzo is a PhD. He's probably the world-renowned endocannabinoid system expert. And he's quoted as saying the endocannabinoid system is essential to life, and it relates messages that affect how we relax, eat, sleep, forget, and protect. And I like to put that in there because what are these things? These are like basic quality of life things, right? And when these get messed up, we don't feel good. And so we all learn, like, if you have, a trauma and, like my dad fell down some stairs and he ripped some tendons off his shoulder. And so he can't lift his arm up over his head anymore. He can only go really horizontal. He can live with that. And it's not affecting any of these other things. But when these are affected, it's hard. Life can be very difficult. So I just want you to think about the endocannabinoid system providing a target for the plant compounds to come in and help keep you in balance. And I see that all the time in my practice. People say, I had a patient that came in on a Friday and she was just miserable and I felt so bad for her. I had called her on Monday and she goes, oh, I'm fine. I slept all weekend, so I feel great. And it was as simple as that. And it had been that she hadn't really had a good night's sleep in months because her pain was out of control. Now, there is something that's described as an endocannabinoid deficiency or dysfunction. And I have already mentioned that, like, if you don't eat healthy fat, you may be depleting your body of your endocannabinoids, your ability to make them. You make them when you need them. And then your body uses them, releases them, they target that receptor, and then enzymes come along and chew up the ingredients so they can kind of be recycled. But there are people who do have, apparently, and we have found in all of these conditions listed here, and just because you have one of these doesn't mean you're going to have the others, but they may not make endocannabinoids very well. They may not have really good functional receptors. This is coded in your genes. We talk about migraine, fibromyalgia, and irritable bowel syndrome. These are 3 particular conditions that nobody really knows, like, where does it come from? Why do people have this? What's happening? It's like a a hyper pain sensation that you get. And remember, your endocannabinoid system's job is to help you manage pain. It helps dampen down pain. When you stub your toe, your endocannabinoids are released. So it seems that some people have this endocannabinoid deficiency. This was first, here it says 2008, but it was really first floated earlier, a few years earlier. I think here, 2004. And then since then, we've had studies on all of these conditions where there's evidence of people having a dysfunctional or deficiency in their endocannabinoid system. And remember, if a physician doesn't acknowledge the fact that you have this system, they will not target it as a point of treatment. And that's why it's so important that doctors start coming around to this, because I can give you, if your endocannabinoid system is often, like, think about a target that you might be, shooting bows and arrows at. I can give you medicine that goes all around here, but if I don't, it's a root cause. If I can treat that root cause, then we can get your system back into balance. All right. Now we're going to just shift to the plant. So let's talk about the cannabis plant. This picture here all the way to the left is the flower, what's called the flower of the plant. It's not a typical flower. And then if you look up close, what you see here is what we call the trichomes. They're these little antenna-like structures. They're basically the factory where the plant makes all the little cannabinoids and some terpenes in there, which are essential oils, and I'll mention those in a minute. But basically, if you could grab this and squish it in your finger, which would be really hard to do because they're really microscopic, you would feel like oil. These are fats, they're lipids, they are like fatty acids. Here are just some of them that fall into the family of what we call phytocannabinoids. So THC, CBD is here, CBN, CBC, CBG, my husband calls it alphabet soup. But all of these compounds, there's a family of about 160 phytocannabinoids. Unfortunately, due to the prohibition in studying cannabis, we are behind the 8 ball still, or kind of in the infancy of learning what all of these different compounds do. What's interesting is that when they are taken together, which is kind of the opposite of a pharmaceutical model. When you think of a pharmaceutical, it's usually one compound that targets one specific place. Cannabis has lots of compounds. They all seem to balance each other and help each other work better, and that's what we call the entourage effect. Other terms for it are ensemble effect. Some people just call it synergy, but it's absolutely well known that the whole plant, because there are studies that show this, the whole plant works significantly better than if you just isolate a single compound. And that's been shown in studies on epilepsy, studies on pain, and so on. And so understand that the plant, that flower is very important. And this can be made into lots of different types of products. And so that's something that we'll talk about as well towards the end of the discussion here. This is what happens in the plant. It's not terribly important, but what I just wanted to show you is when the plant is in this particular phase, obviously it's raw, right? This is like in your garden and it's raw. And then what happens is the plant has this one parent compound, really two, but the main one is CBGA. A minor parent compound is this one with the V in it. But what happens is as the plant matures, it makes all these other compounds, THCA, CBDA, CBCA. If you see an A at the end, it means it's raw. So if you saw a tincture bottle and it said CBDA, you already know, okay, that's raw. The A stands for acid. It's just how it comes. Now, the plant is raw, but then what do humans do to it? So we bake brownies with it, we light it on fire in a pipe or something like that, or we cook up a tincture. When you heat it, you get THC and CBD. This is why people smoke cannabis, is because the raw form does not make you high. It does not have any intoxicating effects. Raw cannabis will not make you high. And we used to think that you had to heat it up in order to get the medicinal benefits, but actually it turns out that these raw compounds have anti-cancer, they have potent anti-inflammatory effects, They also have some anticonvulsant effects, and they also, in very low doses, and again, just the studies have been just done in animals for this particular study, in low doses, both THCA and CBDA, which are available as tinctures, as liquids, have tremendous anti-nausea and vomiting effects, which nobody expected. So I'm glad that there were researchers that looked into that. So if you have a plant that has a lot of THCA based on, and all of this is based on the genetics. It's kind of like, you know, mom and dad both have blue eyes. The baby's likely to have blue eyes, but mom has brown eyes, dad has blue eyes. Who knows what it's going to look like? That's kind of what you have to think about with the plant. If it's high in THCA, it's going to be a high THC plant once somebody heats it up. If it's a high CBDA plant, it's going to have high CBD. Now, by the way, I just want to point out, because I don't think I have a slide on this, what's the difference between hemp and what we call cannabis now, or what people used to refer to as marijuana? The term marijuana, there's two different schools of thought. Some people feel like it's racist because of the history that it was kind of like came from the Mexican or Latino community, and it was used by people to be derogatory, that people of color smoked marijuana. But some people now say we should take that name back and be proud of it. Right now, people are using hemp and they're using cannabis. And the demarcation is arbitrary. It's what our government decided. Anything over 0.3% THC by weight is marijuana. Anything under 0.3% THC is considered hemp. And what's silly is that a plant can test. If I had cannabis plant or a product and I took it to a lab and I took it to another lab, one lab might say 0.29 and the other lab might say 0.31. It's the same. One would be considered illegal and one would be legal. It's kind of crazy and it's arbitrary. Hopefully one day. To me, it's all the same. It just does matter how much THC is in there in terms of how I'm treating somebody or where they might buy it. But in general, what you can have is plants that are dominant THC. You can have plants that are dominant CBD. Now we have some hemp plants that are dominant CBG. And then there's plants that are mixed THC and CBD, like half and half, or 4 parts CBD to 1 part THC, something like that. So now what happens too is these compounds can get old, they age. And when they age, they oxidize, kind of like the metal you leave outside in the air and light and moisture. It oxidizes and creates rust on the metal. THC turns into a compound CBN, and then there's some other compounds as well. But right now we have a lot of compounds on the market. So CBGA, THCA, CBDA, CBG, all of these are available. CBN is available. I didn't make a slide about Delta-8 THC. You may have seen these in smoke shops or in 7-Eleven or in other places. If you see something with Delta-8 THC, it has been adulterated. It is likely highly contaminated because it is not a dominant compound in the plant. So if something's high in it, that means somebody created it. And because those products are not being regulated, I just say stay away from them because you can get sick from them. And there are now cases of people ending up in the emergency room. The Delta-8 itself is extraordinarily safe. It has been shown to be safe. It's a great antiemetic. There was a study in 1995 done by the father of medical cannabis, Dr. Meshulam, who I mentioned earlier, who discovered THC and named it. He did a study on children getting chemotherapy for cancer, and he gave them purified Delta-8 THC because he's a chemist and he has a lab and he knows what he's doing. And it worked great. The problem is that the people who are making Delta-8 THC now through this synthetic process are not doing it the way a chemist would do it. I call them YouTube chemists. And the problem is there's contamination and they have other compounds in there that can make you sick. So please do not buy those products. All right, what are terpenes? Terpenes give cannabis its stinky smell. These are essential oils. They're found in every plant. When you walk through a pine forest and you smell pine, the pine trees, you're smelling pinene. You can see it right here on the chart. Pinene has been found, pine needles, conifers, sage, and so on. It can help with inflammation and bronchodilation. It also helps with memory. So all of these compounds are found in the cannabis plant and can make the difference between what we call the chemovars or chemical varieties. So if you were to buy a product that helped you sleep, it's likely high in this compound called myrcene, because myrcene is very sedating and relaxing. And it's also found, it shows it here, mango. I have patients that sometimes eat mango when they use their cannabis to give it an extra boost for sedating effects. These are found in other plants, as I've mentioned, or other trees and shrubs. The pinene and linalool is found in lavender, and it's sedating and calming. A lot of people use linalool cannabis plants high in linalool, cannabis plants high in linalool to help with anxiety. There's brand new research showing that these compounds work synergistically with the cannabinoids to enhance the medicinal effects. So remember, if I pull the THC out of the plant and give it to you and there's no terpenes around or other cannabinoids around, you get that full bore effect of THC, which for some people can be very uncomfortable. It's, Mother Nature does a nice job. If you have these other compounds in there, it helps direct the THC for a certain effect. So it's important to think about terpenes when you're using different products. And you may, if you go into a dispensary and you see a product and it's labeled sleep, you might say, oh, okay, so now I know what's in that product. It's probably going to be high in myrcene and high in linalool because it's calming and sedating. Now, I mentioned this a little bit. So cannabis is still categorized by the US federal government as a Schedule I controlled substance. The Biden administration has begun the process to move it to what we call a Schedule III, so less restrictive. Who knows what's going to happen now since the election took place. But Schedule I means no medicinal value, lack of safety, high potential for abuse. I'm not allowed to write a prescription for a Schedule I. That's why we just give what's called a recommendation letter. The 2018 Farm Bill made CBD and other compounds found in hemp illegal. And that means that if it's under 0.3% THC, now since 2018, it's been legal. And that's why there's like so much CBD out in the world right now, because all these farmers decided to grow it. But THC at this point is still federally illegal. The state, obviously states have different laws. I think it's something 40 plus states now do allow for medical. And research is still prohibited. As a physician, I cannot really do research on THC or cannabis that contains higher than 0.3% THC because I'd have to, well, I can do it, but it takes forever to get approved. You have to go through the DEA and something called the National Institute of Drug Abuse and all these other federal things. And it's just, but we may see it rescheduled. I don't know what will happen with this new administration. Now let's get into cannabis and cancer. Here's some of the topics we're going to cover. And so let me go on here. So chemo-induced nausea, vomiting. The first study, scientific study, it was in 1975. They took 20 patients that did not respond to conventional medicine. And by the way, at that time, there weren't very good medications. We have much better pharmaceuticals for nausea and vomiting, but remember, there's still people who don't respond. But they gave patients either THC or placebo, and THC patients had significantly less vomiting with no significant side effects. And that's what led to, in the mid-1980s, a ton of research on chemo-induced nausea and vomiting and using cannabis. And that's when they put out Marinol, was about 1985 or so. A 2007 study compared dronabinol, that's Marinol, synthetic THC, to ondansetron, which is known as Zofran. And they also did a combination. This was 64 patients. And they showed that the response was similar for both drugs alone and in combination. But the nausea intensity and the vomiting retching was lowest with the THC, taken as dronabinol. In 2017, the National Academies of Sciences, Engineering, and Medicine, which is a kind of a federal institution, got 16 experts to review over 10,000 scientific articles. And one of their conclusions was that in adults with chemo-induced nausea and vomiting, oral cannabinoids are effective antiemetics. A lot of people do prefer to inhale. I recommend vaporizing, not smoking, because why do you want to put smoke in your body? But if you vaporize cannabis, it actually is immediate. I had a patient in my office with lung cancer a number of years ago. Her adult son had gone to a dispensary and purchased a bunch of stuff and walked in the door with this big baggie of all kinds of cannabis in there, everything, vaporizer, pens, edibles, tinctures, topical, you name it. And he said, I didn't know what to buy, so I just bought everything. And she felt terrible during our meeting, and she even put her head down on my desk. She was green around the gills. And we dug through the bag and we found a little vape pen. And I showed her how to just take one puff. I'm not allowed to give it to her, but she brought it with her. So I gave her one puff, and within 5 minutes, she was smiling. Her color had come back, and she was so appreciative. She was like, I can't believe it was that simple. It is that simple for nausea and vomiting. You really should not be suffering with nausea and vomiting. And but also if your medication's not working, your pharmaceuticals aren't working, this is a very nice way to have immediate relief. And again, clinical findings, many patients report high efficacy. I have patients that pre-medicate because they know the chemo is going to make them sick before they go in, so they'll take it before they get their infusion, or you can use it as needed. And again, I've mentioned THC inhaled or under the tongue. I do say edible. Now the problem with edible is that if you're already nauseous and vomiting, some of these edibles like gummies or cookie or whatever doesn't taste good, then you also have to wait for it to kick in. It can take up to 2 hours. So what I often will tell people is if that's how you want to take it well before, if you know what your pattern is, take it before you feel the nausea, don't wait. CBDA, as I mentioned, and THCA in low doses can be very effective. There's no high feeling with CBDA. Most products that are THCA in low doses do not make you feel any kind of high. CBD in studies of animals has been shown to stop nausea and vomiting, but I have not found clinically that it is really all that great when it's just CBD, high CBD, low THC. Just doesn't work that well. And I have some patients that have come in and said, I really don't want the THC. They're a little nervous about it. But point being that CBD just doesn't seem to work all that well. There's nothing ever 100% in cannabis because everybody responds uniquely. So if CBD is working for you, stay with it. Don't let me talk you out of it. But my experience is that if someone's coming to me because they have uncontrolled nausea and vomiting, THC or CBDA is very effective. All right. What about poor appetite and weight loss? Most of the studies are just not great. They're low quality. Most of them use synthetic cannabinoids. And the main issue is that all the studies have all of these different dosing. Some patients had to lose a certain amount of weight because they could be before they could be in the study. Some were in hospice, some hadn't lost weight at all. It's very hard to come to any conclusion from one study. So it's been a little bit difficult, but clinically, what I see is people report that they get munchies, they appetite stimulation with THC, that we also see that THC slows or stabilizes weight loss and also allows people to enjoy food again. It tastes good to them. In my experience, again, for poor appetite and weight loss, THC is the most effective. THCA can be effective. And remember, THCA is that raw form, only really comes in a tincture because you can't heat it up into a gummy or something, because then if you heat it, it's going to change to THC. But it can be effective for some people because I think there's a tiny bit of THC in there, a teeny tiny bit, and for some people, they just respond to that. And as I've mentioned, CBD can be effective in low dose, but higher doses can decrease appetite. I noticed this too in people who are older, 80, 90-year-olds, who takes higher doses of CBD for memory, for arthritis, for sleep, for whatever they're using it for. If you get to a high enough dose, some patients have had decreased appetite. It's interesting though with CBD, for some people it doesn't do anything to their appetite, and other people say they feel hungry from it. Now remember, CBD isn't being taken by itself. There's always a little bit of THC in that mix. Remember that entourage effect, that synergy. And there really is no such thing as isolated CBD. It's very hard to eliminate THC from any CBD product. However, for some people, maybe it helps their appetite because of that little bit of THC in there. It's very hard to know. Now, what about cancer pain? So 30 to 50% of cancer patients experience moderate to severe pain. There's different types of pain: nociceptive, which is physical damage from the tumor; neuropathic, from nerves being affected by the tumor or chemo; inflammatory pain, where your body releases these pro-inflammatory compounds by the tumor or the tissues being irritated by the tumor. And then there's, of course, mixed pain. Maybe you don't fall into one pretty category, right? You have it all. Cancer pain has been described as being challenging to treat. Opioids are the mainstay, but there was a study that came out in 2008 that looked at cancer patients and reported that 50% of cancer patients are being untreated or undertreated for pain. Not untreated, undertreated. And it's really unfortunate, but part of it too is that not everybody likes opioids. We all know the terrible side effects, addiction and overdose, of course, being very a big problem right now with our opioid epidemic, but also you feel brain fog, you get constipated. I'm a person who doesn't tolerate opioids very well at all. And kind of talking about it, I feel nauseated from it because that's the effect that I get. And so it would be nice to have a separate option. And so what does the research show about cancer pain? So animals with tumors had reduced pain when they were given synthetic cannabinoids. And then early human studies, I say early human, not early human, but early, or, back in the 1970s and 80s, there was significant pain relief with synthetic THC, synthetic cannabinoids versus placebo. In one study from 1975, pain relief peaked at around 3 hours and was still near a maximum 6 hours after the dose, which is a very nice long pain relief. In a study from 2013, 39 patients, cancer patients, had no response to chronic opioid treatment. They got combination THC and CBD, so about half and half. That's like that drug I mentioned, nabiximols, that's being used for multiple sclerosis. Again, not approved in the United States, but being used outside the United States, the pharmaceutical grade one. That's that same ratio. People had decreased pain, better sleep, less fatigue, no tolerance, and no loss of effect over time. And clinically, what I find is all of these compounds have pain relieving properties. So if you said to me, I don't really want to take THC, I'd say, well, having a little speck of it in your medicine is good, but you could have dominance of these other compounds. What I have found is the mixed cannabinoids work really well. So some of my patients take 1, 2, or 3, or 2, 3, or 4 products. I usually recommend a combination of CBD and THC for cancer pain, and then I tell people to try other compounds. Higher ratios, so more CBD than THC. So the way I want you to think about the ratio, 25:1 means 25 parts CBD to 1 part THC. 10:1 is 10 parts CBD to 1 part THC. These work really well for inflammatory pain because CBD works really well for inflammatory pain. These lower ratios, so almost half and half, or just a little bit more CBD than THC, can help with these other types of pain. And then all these different combinations. I mean, I have patients on very different combinations. You might ask me, well, how do you find it? You start with one thing and you slowly build the regimen. And I do talk about in my book. But one thing to always point out is that if you're using THC by itself, if you're just taking a low dose under 10 milligrams, you don't really have to worry too much about developing tolerance. But THC can develop tolerance over time. And it appears that when CBD is in the mix, you don't get as much tolerance. And you can actually, that medicine, then you don't have to take a break from it. Why do you build tolerance? If those receptors, remember that receptor, like that, I showed you that lock sitting on that neuron, think about that lock. If it's constantly being hit with THC over and over and over again, it starts to hide. It goes, that's too much. And it hides inside the cell. Because remember, it's not there for THC, it's there for your natural endocannabinoid. And your body has this very dynamic way of trying to stay in balance to like a self-protection mechanism. So those receptors will hide if it's too much THC, but let's say you took 48, 72 hours off THC, they're like, ooh, all clear, and they pop back out. So I always tell people, if you're using THC on a regular basis, can be very effective, and I don't judge. If you need it, it works great. But at the same time, if you develop tolerance, you might have to take a break from it. And if you're suffering with pain, it's hard to take a break from your pain medicine. So I always try to include some other cannabinoids in there. Now, what about cannabis as a cure for cancer? So There are studies that show that cannabis compounds inhibit cancer cell proliferation, meaning from multiplying. They cause cancer cells to commit suicide. The fancy word for committing suicide is apoptosis. So I want you to think about a healthy cell that has a receptor, and that healthy cell is in your brain and it's controlling your nausea. When THC comes and binds to that receptor, it tells the cell, change your message, turn off the nausea, right? We learned that already. On cancer cells, there's that receptor sitting there, and when THC comes along and binds to that receptor, it tells the cell to kill itself, to commit suicide. Okay, so that's what we call apoptosis. That's been very well established in the research. Also causes cancer stem cells to die. So cancer stem cells, if you're not familiar, are cells that are kind of more aggressive. They haven't fully committed to be the full cancer. That's a whole nother lecture on its own, but cannabis has been shown to kill these cancer stem cells. These are the cells that radiation, chemotherapy, very hard to kill these cells, and they're often responsible for relapse or reoccurrence. And so cannabis has been shown in animal studies, by the way, to cause cancer stem cell death. CBD in particular, although THC has been also shown to inhibit metastasis, that inhibit the spread. So cancer cells send each other messages to go off and be fruitful and multiply and find a new place. CBD in particular blocks that messaging. And then cannabis compounds have also been shown to inhibit angiogenesis. This is the terminology. Angio is like blood vessels. Genesis is like birth or origin. So cancers build their own blood vessels. There are chemos like Avastin that exists, that has been made to block angiogenesis, anti-angiogenic, starves the cell by blocking the production of these blood vessels that you're basically are being built to hijack, right? Nutrition and oxygen and all the goodies in your bloodstream. So the way you should think about these cannabinoid compounds is that they approach cancer in a multiple target way, okay? Additionally, there's some evidence that cannabinoids can enhance some chemotherapy. So for instance, there's one particular chemo called gemcitabine or Gemzar. It's being used for multiple different kinds of cancers. But cannabis plus Gemzar in a particular study in animals with pancreatic cancer, it showed that the combination killed way more cancer cells than either one alone. And then also there's about 5 studies that show that cannabis may enhance the effects of radiation by making the cancer cells more susceptible to the radiation. So very interesting. And again, all of this is in animals and test tube, okay? Now, what don't we know? Well, we don't know a lot, even though we use cannabis for cancer, but there's a lot we don't know. So which cannabis should I take? THC cannabis, CBD, CBG, which one, which alphabet should I use to treat which cancer? Which terpenes might be more effective? What other compounds in the plant might be effective? So there's a very well-known researcher in Israel, Dr. David Meiri, who researches cannabis for cancer and other things. And he found some compounds that don't even have a name that appear to be potent anti-cancer compounds. What dose should you be taking? How long? How high should you go? Should you take it once a day, 5 times a day? Like, what's that dosing? How long should you take it for? Which chemotherapies are most synergistic? What about drug interactions? What about other negative aspects? Do any of these compounds make you more at risk for cancer to come back or to spread? I mean, we just have a lot of questions, and that's why the Schedule 3 category would be so helpful. It's not going to change what I do in terms of my treatment of patients, but it will allow researchers to do the appropriate research, and we really need more research. But let's look at what we do know so far. So this is a human, the first human trial. It's 2006, and gosh, there's only 2 studies, so I'm so sorry to say that. But this is Dr. Guzman, who is a PhD in Spain. And what he did was he took patients that had recurrent glioblastoma, And when they went in for their surgery where they took out the tumor, they left in a tube, and he literally directly administered the THC into that space. And what they found was it inhibited tumor growth, and there were no negative side effects. It's a very nice study, but I don't have people coming to me with tubes and directly into their tumor cavity. So not very helpful as a clinician. But we do have this report, and this comes from a pharmaceutical company that is the pharmaceutical company that made nabiximols. So remember, I mentioned that. Here it is. And it's a spray, as I mentioned, half CBD, half THC. And they did a randomized placebo-controlled trial with 21 adults that had glioblastoma. Half were given temozolomide, a chemo, and they called that the control group. And the other half got the same chemo, temozolomide, but also got CBD and THC in this 1-to-1 ratio. And they didn't get very high doses. And the 1-year survival for those getting temozolomide alone was 44%, and 1-year survival for those getting the cannabis in addition was 83%. And then they report that median survival for the control was 369 days, and median survival latest report was 662 days. So there's something there clearly, and it was in combination with chemo. And I have seen this in some of my clinical patients where they came to me with very bad prognosis, stage 4, metastatic cancer, osteosarcoma, lung cancer, brain tumors, where we added in cannabis to the treatment and patients responded. Not every patient responds, and that's why the research is so important that we do. I sometimes tell people, like, I can help you, but I can't guarantee anything because we just don't know enough yet. But we do know cannabis, especially again under medical supervision, is safe. All right, so let's move on to the next one. And this I just wanted to show you, if you are interested in reading, this is a very nice article that was published in April of 2020, probably needs to be updated. But cannabinoids as anti-cancer therapeutic agents. And they had this very nice graphic showing you how CBD interacted with different cancers. These are the receptors that it targets. So I already talked about the cannabinoid receptor. That's the CB1. That's the one in your brain. And remember, I showed you that picture of like the immune system and gut where it lit up, where the cannabinoid receptors were. That's the type 2 cannabinoid receptor, and then some other receptors here with these other initials. But it shows you that that when CBD was studied in glioblastoma, it decreased the stem cells, it decreased the aggressiveness, it decreased the proliferation, and kind of just shows you here the mechanism. Decreased adhesion and migration, increased cell suicide. This blunted arrow means it blocks the invasiveness. And here again, increased apoptosis is, remember, cell suicide. So there's clear-cut evidence in what we call the preclinical animal test tube literature showing that cannabinoids are anti-cancer. And here's like a very similar one for THC. And they made a mistake here. This is supposed to be an up arrow, not a down arrow. So just be aware of that. But decreased cell migration, and so on. So these compounds do have effects, but again, we are behind the 8 ball when it comes to dosing. Now, do I do dosing? Yes. Most of the people that come to me with cancer are usually struggling, and that's why they're coming not only for symptoms, but also, and unfortunately, many of them are pediatric patients with stage 4. And I wish I could share what the parents say. And in fact, a parent posted on Instagram today, a little boy with a terrible prognosis and a terrible deadly brain tumor. And she said, thank goodness for his cannabis. It's the only time he feels better. And so when a parent of a 4-year-old is telling you that, you know it's helping. Unfortunately, we did get some response initially, but his tumor did come back, even though he was on cannabis. Now let's talk about immunotherapy. So there have been 3 studies, and I'm going to just show you these. So this first study showed that cannabis impacted tumor response rate. This comes from Israel. Here's Dr. Mieri, but his partners here are his colleagues. What they found was that they compared people on cannabis with people who were not on cannabis who were taking nivolumab, one of these immunotherapies, and they reported a reduced response rate in those taking cannabis, meaning the cannabis group had a 15.9% response rate versus a 37.9% in people who were not using cannabis. So that was a little bit scary for those out there working in this field. And this was published in 2019. And that's when I said to people, if you're on immunotherapy, I don't think you should be using cannabis. We don't have enough to know if it's going to help you or harm you. And again, remember, do no harm. And so one of the things about this, though, was that these people weren't even using high doses. They were just using for symptoms. And so that was a little bit scary for us because, again, do no harm. Then another study came out in 2020 that showed, compared 34 people using cannabis and 68 not using cannabis. Here are the 5 immunotherapies that they used. And what they found was that people using cannabis had a decreased time to tumor progression, meaning their cancer progressed more quickly. 3 months if you used cannabis, whereas tumor progression didn't happen for an average of 13 months if you didn't use cannabis. So that's not good. We don't want that. And also decreased overall survival, 6.4 months for the cannabis users versus 28 months for those who were not using cannabis. The only thing cannabis did, though, for these people is that the immunotherapy can cause immune-related adverse events or adverse side effects, and the cannabis dampened that down. So what are we afraid of here? Well, remember, immunotherapy means a treatment that harnesses your own natural immune system to fight the cancer. And cannabis can dampen down your immune system, so it's like they negated each other, and that's maybe why people did not do as well. Then there was a study that came out, and I think this was 21 or 22, and it says a sigh of relief. Okay, what did they do? And again, similar researchers. In mice, they looked at what we call immune checkpoint inhibitors like nivolumab, and they looked at pembrolizumab, I think, as well. And oh yeah, here it is. In mice, they found that the THC did not reduce the efficacy of this drug. So they found the opposite of what they're reporting in these first 2 studies. Then they took 201 consecutive metastatic non-small cell lung cancer patients who were on pembrolizumab. And they found completely different results than they found in this previous study. No cannabis was 6 months the time to tumor progression versus 5.6 months for people using cannabis. So almost the same here. This was not statistically significant. And then overall survival, 54.9 months in those using cannabis versus 23.6 months in no cannabis. Like, what the heck, right? So NSS means not statistically significant. So these numbers could be due to chance. They weren't because of the cannabis or because of no cannabis. But what happened, and that I'll share with you, is just earlier this year, some other researchers went back and looked at these 2 studies, these first 2 studies, and they found some statistical errors. And so what we were basing our treatment on may have been due to some statistical errors, like math errors, basically. And so to me, it's still up in the air. I try to just do case by case as a cannabis physician, but in general, if somebody's on immunotherapy, the last thing I want to do is give them cannabis to negate it, because that doesn't make any sense to me to take a drug and then negate it with another drug. And so what I tell people is give your immunotherapy a chance to work, or don't, but don't use cannabis in combination with immunotherapy unless you have medical advice from somebody who knows what they're talking about. And so that's what I tell people. I do case by case. I have had patients on pembrolizumab who have non-small cell lung cancer, and I feel comfortable because this study does give me some support. But in a child with metastatic bone cancer, no, we're going to try the immunotherapy, because the last thing I want, again, is harm. All right, now we're going to move on to methods of delivery. And so this is different ways to take cannabis. I've already mentioned with inhalation, there's a very quick onset. It peaks at about 30 minutes or so, and then it kind of falls off the curve, and it's about 1 to 4 hours depending on your dose. It's very easy to dose if you start with 1 puff. Just wait for the effects, give it a chance to work. You can always add more. Excuse me. What you don't want is to puff, 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 and 30 minutes later, you're freaking out and you're anxious and paranoid, right? Nobody really wants to experience that. Under the tongue, depends on what is in the product, like in terms of like if there's a little alcohol or something in there, it may absorb a little bit better, but somewhere between 15 and 60 minutes. I do have some outliers who tell me it doesn't kick in for an hour and a half, but basically you would squirt an oil under your tongue or take a dissolvable tablet, which they sell now, under the tongue, and let it sit there for a few minutes, and then you would swallow it. It peaks at about 1 to 2 hours and lasts 6 to 8 hours. It's discreet, it's easy. Ingestion is like edibles, the gummies that everybody's talking about, the cookies, brownies, whatever. It takes 60 to 90 plus minutes to kick in, peaks at about 2 to 3 hours, and you can get 6 to 8 hours. Some people do get 12 hours, but it is easy to overdose. Why is it easy to overdose with ingestion rather than these other methods? And the reason is that when you eat a gummy, a cookie, a brownie, or drink, they have these THC drinks now, it goes through your gut rather than under your tongue where you have a lot of tissue that it can absorb, or through your lungs. Your gut transfers everything, absorbs, and everything goes through your liver. Your liver changes THC to a breakdown product called 11-hydroxy-THC. Just think of it, it's a cousin compound. The cousin compound is highly intoxicating. So people might say, well, all I took was this little gummy, but your body converts the THC into a secondary compound that's highly intoxicating. So it's always, always, always important to know your dosing with ingestion. Cut even a little gummy. I tell people, cut it into quarters if you never took it before, because you don't really want to have a 12-hour long unhappy paranoid experience, especially if it's just THC. And then topical can work very nicely. It varies in terms of its onset and duration, just depending on what's in it. I lost a teenage boy to osteosarcoma, but he had such terrible bone pain. The only thing that helped him was topical cannabis, and the parents was nice. The company donated it, and they would rub it on and he would have a few hours of relief. It really worked well for him. And remember, anything that you put on your skin is going to stay where you put it. So if you have arthritis in your wrist and just put it there, you're not going to absorb it. It won't absorb into your bloodstream and go to your brain. So you should not feel high or disoriented or anything from anything you put on. And I don't have on here patches. There are patches with THC. If you put the patch on and leave it, those are meant, they're called transdermal. They're meant to penetrate in, and usually there's chemicals, some natural, some not, inside that patch to help what we call with permeation or permeation enhancer, to push it in so you can get it into your bloodstream. I do know people who use the patches. I'm not a huge fan of it because I feel like it's a little uncontrolled, and I like to control dosing. Now, what about side effects? So THC is the compound that causes the high, the intoxicating effect. And it is the one that you always are very careful in terms of your dosing. But side effects are mild, moderate to moderate, temporary, and dose dependent. When you look at, and I have read the research because I wrote a book, 2 books, and you have to read all the research if you're going to write a book. I cannot find a study that shows very severe. Now, we hear about people freaking out. We hear about people like getting paranoid and anxious and calling 911. But the reality is once it wears off, you're fine, and it's reversible, and there's no damage done. And again, that's not, I always tell people, we're not talking about teenagers who are abusing. We're talking about medical use. THC side effects are temporary, they're dose dependent. So it's always, we have a saying, start low and go slow. Don't take too much. If you don't know your dose, investigate, look, talk to somebody about it. But some people get munchies that they don't want, and that can be, but some people get munchies that they do want. So it just depends on your situation, whether appetite stimulation is something you see as a side effect or not. Sedation or agitation, some people can get irritated. Some people just fall asleep. Anxiety, paranoia. Because you have receptors in your heart muscle, there you can get a fast heart rate. If that receptor is triggered by THC, that can make your heart rate go fast. It's never any more fast than kind of running up a flight of stairs. You can also get low blood pressure. There are people who get dizzy and can fall from THC, especially if they're new to it. Dry mouth, red eyes, short-term memory loss, and loss of motor coordination. This is why you shouldn't drive your car if you're using THC. That doesn't mean you can't drive your car. If you haven't taken a dose, you can drive your car. Just because you use THC does not mean you shouldn't drive, but you shouldn't drive if you take an edible for at least 6 to 8 hours, and if you inhale it, at least minimum 3 hours before getting behind the wheel of a car. One thing I wanted to say about this was, there are studies that show that for most people, the side effects from THC are really mostly occur in the first couple months. Why? Well, because that's when you're figuring it out. Once you figure it out, you don't have side effects. And my patients that come back year after year, I always ask, are you having side effects? And people are like, no, why are you keep asking me that? Because they figured out what their dose is, they're on the appropriate dose, and they're not struggling with any side effects. Now, CBD in general, very rare side effects with low doses, uncommon with higher doses, but we have seen sedation, GI upset or diarrhea, decreased appetite. And actually this, I'm missing a bullet point here. In patients taking liver toxic medications, if you take a very high dose of CBD with those very high doses of your liver toxic medicine, your liver function tests, the blood tests that check for your liver can go up, but it's all reversible once you remove whatever the toxic compound is. There is no known mechanism to cause a fatal overdose, but overdoses can happen and they're unpleasant. You can feel anxiety, paranoia, sedation, what we call dysphoria, the opposite of euphoria. So it can be very unpleasant. There's a well-known 911 call from a police officer and his wife who took, he confiscated someone's cannabis and he went home and didn't turn it in. He made brownies from it, and he and his wife totally overdosed, and he calls 911. He's like, time stopped and we're dying. It is not unusual for people to feel that they have this perceived sense of doom or death or, demise, but it's all in your head. It's just the cannabis messing with you. So, but I do not advise overdosing. And that's the point of medical cannabis, is that you never have to overdose. All right, sources for patients, the last screen here. So my book is available. If you're looking for a cannabis specialist, you can look at cannabisclinicians.org. There's also myself. I just opened my practice. I have 2 different programs. It's like a concierge practice that for a whole year, or you could do a one-time educational consult for a lower payment. And then if you need follow-up, it's just like, a lower visit, but one includes emails and the whole year of treatment. One is just a kind of one-off. There's also Dr. Sherry Yafai at the Relief Institute. She's excellent. She's in Santa Monica, but does telemedicine, and I do telemedicine. There's a free book online by a young man by the name of Justin Candor that kind of reviews all of the scientific literature that we just talked about. I only gave you little bits and pieces, but he goes through a lot of it. I would say it's a little slanted, so just go with a critical eye. ProjectCBD.org is a nonprofit that has just great articles written very nicely and telling the truth about things, and I just really like that website. This book here, and I don't get any money to promote it, but it's available on Amazon, was written by a colleague of mine, and it's just came out this year, and it just does a very nice review of all the research. You can also go to Google Scholar and you could type in cannabis or cannabinoid or marijuana or whatever term you want for, I would just say use cannabis or cannabinoid, and you can type in your type of cancer or just the word cancer, and you'll get a whole slew of articles that you can read about your particular situation or your type of cancer, whatever it is you're interested in. And then I just want to share, and I just added this last minute, I just started a new company called Goldstein Wellness this year in 2024. This is not meant for lay people, it's meant for state licensed clinicians. So MDs, DOs, chiropractors, acupuncture, nurse practitioners, anybody that has a state license to practice medicine or to be involved in healthcare can sign on, and it gives free education, free dosing guidance, and it's paired with some hemp products so to keep the website up and running. And doctors can invite their patients on there and can give their patients a discount on hemp. And so if you have a physician that you have seen to be open to cannabis and they're looking for more information, please share the website. It truly is free education, because I'm tired of being the only one doing this. And I think we need to have more doctors who can at least have a honest, based on science, based on evidence conversation with their patients. And so that's my talk for tonight, and I'm really happy to take any questions.
Wonderful. Thank you so much. That was just a whole wealth of information. We do have some questions. Some were directed to me, so I'm just going to read them out loud. I have been getting a natural high when I'm anxious. It's kind of scary, but now that it's happened 4 times, I'm starting to recognize and accommodate it better. Could it be my endocannabinoids responding to stress?
Yes, it could be. Absolutely. And so we've all heard of the runner's high, right? And people call it it's in your endorphins. There is not 1 ounce of evidence that it's your endorphins, it's your endocannabinoids. They've shown this, that when you exercise, your body releases your endocannabinoids. So absolutely it could be. And I've had other patients describe that in relation to pain or in relation to really anything. I've seen it with anxiety. I think I have felt it with anxiety, where I'm like, oh my goodness, like, what is that? What am I feeling? And I've tried THC before and it feels similar. So it certainly could be your endocannabinoid system kicking in.
Thank you. Next question. I don't know if I'll be able to ask this question, but LA Times has been reporting that commercially based cannabis products are contaminated by pesticides and additives. Are you able to share some source clean products?
So I really can't endorse any products, but what I tell people is that it's important. Like, I have what comes into my mailbox from the DCC, any of the recalls. They are trying very hard to recall cannabis. I have not had any patients, even before 2018. So remember, in California, we voted in 2016 for adult use. But at the same time, what we also voted in was regulation of the medical program. All of that went into effect in January 2018. So between 2008 and 2018, I had patients using cannabis that was not required to be tested. And I just did not see people getting sick from it. Now, that doesn't mean I want you to use whatever. You have to use your judgment. There are companies out there going above and beyond, but it's hard for me to endorse because the medical board doesn't want me endorsing. But what I tell people is, when you go into the dispensary, ask them, is this company, do they have recalls? You can go to the DCC website before you go to a dispensary, or if you talk to a cannabis practitioner. It doesn't have to be an MD. There's lots of nurse practitioners that have practices and so on. But you should ask, because, like, I can tell my patients, but I'm just not supposed to endorse here. So, but that's between us, between me and my patients. And yes, but I would say it's the minority of products. It's not something I'm overly concerned about. But there's always the chance. And if you subscribe to the DCC newsletters and whatnot, you will get those in your inbox if you are using cannabis.
Wonderful. I just want to reiterate that this workshop is being recorded. So I did add my email. If you would like a copy of the recording, or if you're from a different CSC affiliate, you're more than welcome to email your point person there in a few days once I get the email recording to them. But yes, it is available. Did the immunotherapy studies test CBD only?
They didn't. It was really, so this is one of the frustrating things about these studies, is that they don't always outline what people are taking. But in Israel, when patients are using cannabis legally, the ones that are being in these reports, they're usually getting just a small amount of cannabis from a dispensary. They have a nice system there. I mean, it was better before they changed it, but you would go to the dispensary and there was an RN there who was knowledgeable, or a nurse practitioner, and they were sharing information. Like, you actually met with a medical, once the doctor approved, in Israel, you have to be approved by the Ministry of Health. So they submit paperwork, they'll approve you, and then you meet with a healthcare practitioner who's familiar with cannabis, and they kind of educate you. But they didn't, my understanding is nobody's there taking very high doses, and that many people are using THC in combination with CBD. I don't know that it was CBD only, but I don't think it was.
Thank you. What is the difference between CBD versus CBN?
Okay, great question. So CBD is cannabidiol. And if you remember the slide, it showed you that's like when you heat up a plant that has CBDA in it, has some genetic predisposition to have some CBDA, you make CBD. CBN is the breakdown of THC. So if I left, and forgive the way I'm going to say it, if I leave pot laying around exposed to heat and light, it changes. It changes its chemical structure just the same way iron, like if you leave metal outside, it gets rusty. So that's called oxidation. It oxidizes. Well, THC oxidizes to CBN. So they are completely different compounds. CBD is cannabidiol, CBN is cannabinol. CBD does not bind directly. The reason you don't get high from CBD is because it doesn't bind like THC, like a key in the lock. It kind of, when it finds the receptor, it kind of sits on the outside of the receptor and it regulates what's happening at the receptor, but it doesn't bind directly, and that's why you don't get high from CBD. CBN binds to the receptor. It's a cousin of THC, but it is a quarter of the potency or so of THC. So it's kind of like a weak. The other thing is the CBN seems to like the type 2 cannabinoid receptor more than the type 1. The type 2 kind of is involved in inflammation and immunity. So there are some patients that are using CBN to try to help with inflammatory conditions. I hope that's clear. Yeah.
Yes, interesting. Thank you so much.
Oh, and I just want to talk about one other thing about CBN. Everybody in the dispensary saying, oh, it's for sleep, it's for sleep, it's for sleep, it's for sleep. Okay. There is a study a review of studies that came out in 2021. Forget the title of it, but basically it reviews all the studies up to 2021. No evidence at all that it helps you with sleep. And then there was a study that came out the end of last year where they gave 20 milligrams of CBN versus placebo versus different doses of CBN combined with CBD. And the only one that seemed to help a little bit with sleep was the CBN at the 20 milligrams. But I will tell you, in clinical practice, for sleep, I like THC or THC combined with low dose CBD. CBD in low doses has actually been shown to give you an alert feeling. They're actually doing studies on CBD for narcolepsy. Narcolepsy is when you fall asleep in the middle of the day. Why would you give somebody CBD if it's going to help them sleep and give it to somebody with narcolepsy? Very important part of these compounds. THC in low doses can help with nausea, vomiting, anxiety, pain, but in higher doses can actually cause those things. Okay? CBD in lower doses can be alerting. CBD in higher doses can be sedating. We call this biphasic. Two different opposite effects at different ranges of dosing. So dosing matters. And that's why we always say start low and titrate up. And I will tell you, there's a lot to be said for individual differences. You may have a friend who thinks cannabis is the best thing ever, but you were born without a great way to metabolize this. I've met children with autism who cannot break down these compounds. And how do we know that? Well, because we couldn't figure out what the heck was going on. So we did a test of, a swab on their mouth or some blood work to look and see how they metabolize, and they don't break them down. So everybody's individual. And one of the things we say in the cannabis world is we treat the patient, not the condition, because you as an individual may have a different response than somebody with the same exact condition that you have.
Wonderful. There's quite a few questions. So the next one is
Good.
try. Yep. There's a comment, I guess, about try different strain, use indica strain. I am on Elahere, ELAHERE. Can I use cannabis?
So I'd have to look that up. I would have to look that up, and I don't know. So, and I don't really like giving advice just on one sentence, but the best thing to do here is to probably, I don't know what that is. So I'm sorry, I'm not familiar. Is it an immunotherapy, whoever the person is? So Giselle, if it's an immunotherapy, I would probably be very careful. And I would say that you need to kind of have a conversation. By the way, I forgot to mention in the that very last slide that had the resources, There is a wonderful group of nurses, and they go under LEAF 411, and they offer either free or very low cost evaluations if you just kind of want to get a quick advice, right? Something semi-simple like a drug interaction. They should be able to help you with that.
Wonderful. How well will cannabinoids work for patients with non-cancer neuropathic pain, such as a post-motor vehicle accident?
So it's interesting because you have to remember that there are studies and then there's clinical, what we see in patients. I have patients with what we call neuropathy, neuropathic pain, nerve-based pain. They swear this is the best thing ever. It works great. It completely eliminates the pain or lowers it to a point where it becomes very tolerable. It's one of the things about cannabis too. It helps you kind of become in charge of your condition rather your condition controlling you. You get to control it, even if it's not a cure. But I have patients that do very well. Neuropathic pain has been studied in multiple sclerosis patients using that nabiximols, which is that half and half CBD THC. There's also some evidence that THC and CBDA might be a good combination, and now some people are saying CBG, cannabigerol. So when you say how well, clinically, I have seen very good results. If you just read the scientific literature, what you'll see is it helps some people, but not everybody in the study. But that's what we say about with cannabis. When you pick if I were to do a study and I picked one particular product to give 100% of my patients, my participants, it's not going to work for everybody because there is no one size fits all. We treat the patient, not the condition. So in real world, if let's say I said take a 1-to-1 ratio CBD THC and it didn't help you, we'd find something else under the cannabis umbrella to try. So I always tell people you can read the studies, but remember they're not the end all be all because it's hard to study a plant that has hundreds of compounds and tons of different products because it's really, you're not studying cannabis, you're studying that particular product and it may not work for everybody with that similar condition. Hope that's clear. Yeah.
Wonderful. For any of the drug interaction questions, I did put the leaf411.org into the chat for that hotline that Dr. Goldstein just mentioned. Next one was, all right, if you can talk about, you didn't mention an issue with Keytruda. I think that's what the research.
Yeah, again, so there's some evidence with Keytruda that it's actually okay. But again, I would say that it's important to talk to somebody who's knowledgeable in the cannabis world because there may be something that you would want to know. So, and dosing would matter and so on. So I worry that people are going into a dispensary and getting advice from someone behind the counter who unfortunately worked at Ralph's last week and now they're behind the counter. And so are they really, they're not healthcare professionals. And when people go in and say, I have cancer, they don't ask you, well, what drugs do you take? And, what's your, what else is going on? I spend an hour to an hour and a half with new patients. So why would I do that if it's just so simple to say, oh, just go by this or just go by that? It's really an in-depth, tailored, not cookie cutter approach. So again, with Keytruda, I have had patients who have used it without issues. Right now, I actually have 2 patients on Nivolumab that came to me on Nivolumab and cannabis, but they wanted more advice and they're doing okay. So I'm not going to discontinue and they've been stable or, scans are clear, but I'm still, we want to be cautious. Again, do no harm.
Next question. So how can participants connect with you for services? What's the best way to get in touch?
So my website is easy. It's Canna, C-A-N-N-A, or I could put it in the message here. Or actually, you know what I can do? The best thing to do is just call my office. And I do require medical records to be submitted to see if it's something that if I'm not going to take your money if I can't help you. So we try to, and if I can't take you, I will try to let you know why, right? Okay, so that's our phone number, extension 3, and ask for Margot. That's who you want to, she's my right hand. And there it is. All right, so that's the phone number. And then if you want to see Dr. Yafai, I think I put her website, the Relief Institute. So, yeah.
And then what do you define or consider a low dose of CBD and a high dose for CBD?
Yeah. You guys have great questions. That's awesome. So what I tell people is really and again, we're not going to talk about children. So in adults, Really anything over 50 to 100 milligrams of CBD is kind of considered a high dose. There are people taking 10, 25, 35 milligrams. We kind of consider that low dose. We really don't see a lot of drug interactions at the lower doses. Just so you have a sense, I have pediatric or young adult patients, I specialize in epilepsy and autism because of my background in pediatrics. I have a young adult in my practice that takes 1,600 milligrams of CBD to maintain seizure freedom. And so that's considered a really high dose. I have my own mother takes about 100 to 150 milligrams. You might consider that high dose, but it doesn't interact with her other medications and doesn't really cause any side effects. Now, I didn't start her at that. If I were to start a patient at 200 milligrams right out of the gate, they would be horizontal snoring and they would not be happy with me. So you always, again, start low and you titrate up. You're looking for what we call the minimal effective dose. That's the dose that gives you the benefits you're looking for, but without side effects.
Wonderful. I want to confirm, are you located in Lawndale, your office?
So I no
okay.
longer,
Okay.
yeah, since COVID, I just do strictly telemedicine.
Okay.
Yeah.
So
And
there's
so
a
I
question
can,
about
yeah.
what service area. So anywhere, because it's telemedicine.
Yeah, it's telemedicine, and wherever you live in California. I can only see California residents because that's where my license is located.
Okay. Does any of your service or any of your services covered by insurance?
Unfortunately, no. We are cash pay. We are trying to work on getting insurance, but patients can get reimbursed. We can give you a super bill, and if you have insurance that will take the super bill, you can get reimbursed. So many of my pediatric patients do get reimbursement for the visit.
Wonderful. And back to that question of Ella here. Ella here is an antibody drug conjugate, ADC.
So anything with antibodies, I would be very careful because cannabinoids can suppress function of antibodies. And again, it's always like, until we have more research, and again, it's do no harm. And so I just want to make sure that somebody's not being harmed. And I started to say earlier, I get worried when somebody walks into a dispensary and just says, I have cancer, and then you may start cannabis and then it negates out the treatment that you're getting. We haven't seemed to had any issues with standard chemotherapy radiation. And in fact, there are studies that show synergy there, but immunotherapy is a different creature. And so until we know more, it just makes me nervous. I don't want to harm anyone or give them bad advice.
Thank you. Last question. Someone from our sister affiliate, Valley Ventura Santa Barbara, is unmuted. Did you have a question?
Oh, I'm sorry. No, I didn't know I was unmuted, but I'm thoroughly enjoying your lecture, and it's very informative. Thank you. I look forward to sharing it with all my support groups too.
Absolutely. Thank you so much, Dr. Goldstein.